Dr. Christensen is a clinical associate professor at the Wayne State University School of Medicine. He is the medical director of the Michigan Health Professional Recovery Program, the James Wardell Women's Recovery Center, and the Tolan Medical Research Clinic in the Department of Psychiatry at Wayne State University. Dr. Christensen is a fellow of the American Society of Addiction Medicine and a past president of the Michigan Society of Addiction Medicine. He has received numerous teaching awards and has been named one of the top docs in addiction medicine in our magazine for several years. He is also the medical director for Dawn Farm. Please help me welcome Dr. Christensen.
Thank you. So first thing I'm supposed to go through every time is disclaimers about where my money all comes from. As they mentioned, I'm the medical director at Dawn Farm. I'm the medical director of the Michigan Health Professional Recovery Program that monitors addicted doctors and nurses, and we'll be mentioning that a little bit. I work for the government on identifying doctors who have overactive prescription pads, and you probably know a few yourself if you're here. And I'm a consultant for Blue Cross Blue Shield for the same thing, and also for safe prescription practices. And I work with both 12-step recovery programs and medication-assisted therapy, including Vivitrol and Suboxone and Methadone, and we'll be talking about all those tonight. And I like to tell everybody that I'm fair-minded. It's also been described as promiscuous, so I'll let you decide what the correct definition is here. I think this article is still on the Dawn Farm website. We got permission for it. It's written by Nora Volkov, or most of it has been written about her, and it's an excellent description of different parts of the brain and how they're affected with addiction, even though it's about 10 or more years old. So you should be able to find this if you go to our website. So the first thing is, and this sounds kind of redundant, we have to talk about what the definition of addiction is. And probably there are as many different definitions as there are people here in the room tonight. And I just want to go over the most popular ones. The most common theory is that it's physiologic, meaning that, if only I can stop this Vicodin or Norco and get over the withdrawal, everything will be okay. But the reason I'm addicted is I can't get over the withdrawal. We'll talk about that. Or it's a lack of willpower, and you're just a weak-willed person. You need to suck it up, get over it, and just get on with your life. Or you're a bad person, you're immoral, and you should be punished. And as you know, the majority of people in Michigan prisons have a history of alcohol or drug problems. Or it's an actual mental illness. So we'll look at all of these. So the first one is talking about physiologic dependence, and the terms here that you need to know are going to be tolerance and withdrawal. Probably most of you have heard these. Tolerance means that I need to use more to get the same effect, and withdrawal means that I have the opposite effect when I stop the drug. So if I need a few Xanax every day and every evening to handle the stress of life, I'll find that after a while I'll need 2 Xanax and then 3 Xanax, and I have patients who take up to 20 Xanax a day just to stay calm. If I stop taking that medication, the opposite will kick in. I'll get anxious, jittery, irritable, and if I've been taking enough, I can have a seizure. Now I'm going to make a statement. Neither one of these have anything to do with addiction. I can take everybody here in the room and force feed you morphine for 2 weeks and then suddenly stop. Everybody here is going to get physically sick. And you'll have diarrhea, cramping, sweating for a few days, and then it'll be gone, and 85% of you will say, thank God that's over, I never want to go through that again. About 15% of us, maybe a little more here in this room, will say, I'm going to go out and start robbing party stores so I can get more morphine. Because taking that morphine has activated the disease of addiction in us. And I'll show actually how that happens in your brain. But you can have cancer patients, chronic pain patients who are on high-dose pain medications, and they are tolerant, they have withdrawal, but they don't have addiction. So this is what we just talked about. All right. So just to show you, talking about the different parts of the brain, the part of the brain that is affected by withdrawal is in the hindbrain, the very back of your brain, and that's actually called the locus ceruleus, and that's identified as LC here on the screen. The part of the brain we're going to be talking about tonight is the nucleus accumbens, which is the pleasure center, and that's the addiction center. That's what we're going to be focusing on. Another theory is lack of willpower. Addicts are weak-willed, and you can take a lot of people from history. I picked 4 here who were alleged to have a problem with alcohol and drugs. The 2 on the left were alleged to be amphetamine addicts. The 2 on the right were alleged to be alcoholics. And I used to always, when I give this talk at the different medical schools, I used to give a little blurb about how Winston Churchill was not an alcoholic because no alcoholic ever drank that much. And I realized after a while that no one in the audience really seemed to know who Winston Churchill was, which is the depressing part, so I stopped that blurb. But no one has ever accused these 4 gentlemen of being weak-willed. And history is full of strong-willed alcoholics and addicts. It simply does not correlate. Now, this is somebody who should know, okay? This is a gentleman who was arrested for doctor shopping, carrying around boxes of cash to trade for OxyContin, who went into treatment as part of a legal deal, and the day he got into treatment, he disavowed all of it. This is somebody who, I used to have the phrase on top, oxymoron, but I got a lot of complaints about it, so I stopped doing it. But this is an example of somebody who believes that addicts are simply weak-willed people, and his only problem was that he tweaked his back. So, how about being a bad person? Everybody here knows who the guy is on the right. That's Sigmund Freud. Sigmund Freud was a cocaine addict. He became addicted to cocaine while he was trying to treat his oral cancer from the cigar there. He also thought that cocaine was a treatment for alcoholism and found out that he was wrong. The guy on the left is the greatest teacher of surgery in the U.S. That's William Halsted. He's a surgical oncologist, and he was considered to be the greatest teacher there ever was. He was a hopeless cocaine addict. And not only was he addicted, but he got his fellows and residents addicted. And you can only imagine what rounds were like with this guy in the morning. Matt Statman, who previously worked at Don Farm, found the only article he had ever written and passed it around to us. It was completely unintelligible. He wrote it when he was high, and the first page is 1 sentence. Okay, you may have seen somebody using drugs who talked like that, and Dr. Halsted wrote like that. But no one has called these people immoral or bad people. They were, unfortunately, addicts who were not, as far as I know, not cured. There's actually a special PBS about them, about how cocaine destroyed both these gentlemen's careers. So we're left with talking about a brain disease, and that's what we're going to focus on tonight. So the culprit here, or the source of tonight's talk, is what's called the nucleus accumbens. Don't worry what it means, because I don't know. But that is an area in the primitive forebrain that responds to outside cues by causing craving, and when you do those things or take those things, you get pleasure. And we'll talk about the gas tank for the nucleus accumbens, which is right behind it in the midbrain, called the ventral tegmental area. And that really means a roof on the bottom, okay? And the drug involved going from here to here is dopamine. Dopamine is a pleasure drug. And this is a slide I got years ago. Darryl Strawberry, who was a really, really bad addict, a cocaine addict, destroyed his career, was in front of the judge multiple times, and one of the times that he was in front of the judge, he told the judge, "My brain is broken." And he knew what the problem was. At the time, he did not know what the solution was. I don't think his career ever recovered. And this slide is like 10 years old. And last year when I was going over this talk, I just wondered, whatever happened to Darryl Strawberry? Did he die from drugs or spend his life in prison? And he founded the Darryl Strawberry Recovery Center. I'm not even sure, where it is or what he does, but he got into recovery and he maintains a recovery center now. So this is a primitive brain. This is a rat brain, and the front of your brain right now is over to your right, and the hindbrain is over to your left. And this is the hindbrain, the midbrain, primitive forebrain, and the most advanced forebrain. And this is a rat, so the part that's the biggest in us is actually the smallest in the rat. And the areas here we're going to talk about are going to be the nucleus accumbens, which is your pleasure center. It responds to dopamine. by making you crave something, and then when you use it, you feel great, and it leads you to use it again and feel great again, and so on and so on. In a normal person, that response is damped down or tamped down, and you don't keep on doing it over and over again. The source of the dopamine in most cases is the gas tank right behind it, the ventral tegmental area, and if you look, all the drugs of abuse we're going to talk about are acting either directly on the pleasure center or by the gas tank right behind it. Both these areas are broken in addiction. We'll show you how they are. There's more bad news. Now, those of you who are normal, if you go out tonight and stop on the way home and have a couple beers, you're going to say, well, I'm only going to have 2 so I don't get a drunk driving ticket. That is your prefrontal cortex inhibiting your pleasure center so that you don't wind up in jail. If you're an addict, I'm going to show you how the prefrontal cortex is also broken. The brain scans I'm going to show you will look like they're not even there. Okay? So not only is the primitive part of the brain and the gas tank out of control, the brake lines have been cut. So this is a study done by Nora Volkov, who's the medical director of the National Institute of Drug Abuse. If you look at that paper on the addictive brain, most of this research done is hers. And right now we're looking down at your brain, and this is the front, this is the back. Remember, your brain is cut in half, so you have a left side and a right side. These red areas are dopamine activity. That is your pleasure center and your pleasure drug. And these 3 folks here are normal, happy controls. Red means dopamine, and that's how much you're supposed to have. And over on the right, we have a cocaine addict, an alcoholic, and a heroin addict. And even though we have 3 different drugs, we have the same brains. We have depleted dopamine. And one theory of addiction, which is called the reward deficiency syndrome, says that the reason that addicts do what they do is because they don't have enough dopamine, they don't enjoy life as much, so they wind up doing outrageous things to get the same amount of pleasure that normal people do. So one complaint about this is you can say, well, that's nonsense. All you're doing is you're looking at pictures of brain damage. If you use drugs use dopamine, you burn up your dopamine, and that's all we're seeing. So is it because they have low dopamine they become addicts, or because they're addicts do they burn up their dopamine? So what they did was they did a study on folks who had not yet become addicts out in California. They took volunteers who had negative drug screens, were not using drugs. I'm not sure how they found enough of them in California, but they took those folks and they injected them with methylphenidate, which is Ritalin. So that's very similar to injecting you with methamphetamine. And they said, did you like it? And people said either yes or no. And then what they did was they took brain scans of the folks who had said yes or no, and here's what they found. People who did not enjoy being injected with meth had normal levels of dopamine. People who enjoyed being injected with meth had low levels of dopamine. And these people had not started using yet. Okay? So the idea here is you respond to a stimulus like IV methamphetamine or IV Ritalin according to how much dopamine is in your brain. And how much dopamine you have is probably regulated at birth or by stress or other outside factors. So people who enjoy injecting stimulants had low dopamine. People who didn't like it had high dopamine. So the theory is addiction's an abnormal response to rewards. And if you have low dopamine, you're going to need a bigger stimulus to get the same amount of reward. There's another study, I didn't include the slides because they're just very tiring to look at. But what they did was they took women who had normal BMIs, body mass index, they took women who were obese, and they gave them rewarding foods like milkshakes. And they found that 2 things. The obese women, there was something wrong with their dopamine. They didn't have as much dopamine, which we've already shown. And also, when they looked at the amount of reward they saw in the brain, and this doesn't make sense the first time you hear it, people who were obese didn't enjoy the milkshakes as much. So people who are normal, with normal weight, enjoy milkshakes more than obese people, and you think the obese people are the ones who enjoy it more. It's the other way around. If you don't like something as much, you need to take more to get back to where everybody else is. So everybody who has any interest in addiction, or anybody in your life who has addiction that's affecting you, you should go to an open 12-step talk. I'd recommend coming to this one on Saturday night here right in this auditorium. It's held now at 7:30. The public is welcome. You don't have to want to stop drinking to come. And you're going to hear someone share their story, and it's usually someone who has succeeded in recovery. And sometime during that talk, you will always hear this kind of phrase: I didn't feel normal. I didn't belong in my own skin. I felt less than. And what you're describing is what we call decreased hedonic tone. Hedonic tone is a normal level of pleasure that you feel in your life. If you're an alcoholic or an addict, you feel like crap all the time. And it's not just a matter of being in withdrawal. It's people who haven't even started yet, or people who in recovery will still have low levels of dopamine or low levels of hedonic tone. So I always show this picture to my medical students and residents, and I say, pick the alcoholic and the addict in the room. And people always go down for these kids down here in the front. These kids are having a great time. They're going to grow up to be stockbrokers, so they may do a few years in prison, but they are really enjoying life. Look at the picture. Look at the little girl in the back. Okay? Now, obviously, this is all contrived, but if you are born with decreased hedonic tone from decreased dopamine activity, you are at increased risk of looking for things that make up for it, including drugs, alcohol, and behaviors that we would consider risky. Okay, so the next thing is, why can't addicts and alcoholics stop? Most addicts and alcoholics, either voluntarily or involuntarily, are invited to stop. You get arrested, you go into treatment, you go to AA, you do something. Almost everybody stops somewhere along the way. Almost everybody who stops will relapse. How come? Because the brain is still damaged. I'm going to show you why. This is a picture of brain metabolism. Red and yellow are good. And this is a picture of a normal brain, and this is the front of your brain pointing up. And here's an active cocaine addict. And if you look at the two, you can see there is very little blood flow in the cocaine addict compared to the normal person. And that's not a big surprise if you know somebody who's an active addict. There isn't a whole lot of higher executive functioning going on there. But I got more bad news. This study is the same kind of study looking at brain metabolism. On the top, we have 3 normal controls. And red and yellow are good. Blue shows no brain function, and those are parts of the brain that aren't normally functioning. So this is what you're supposed to look at. Here are 3 cocaine addicts who stopped using 10 days ago. There's no brain activity there. Now you can say, well, so what? That's only 10 days. That doesn't matter. I got news for you. This is where you get discharged from treatment in most cases, if you're lucky to get 10 days. And you wonder why someone relapses on the way home. It's because their brain is still completely non-functional. Down here are people who have 100 days in. They've gotten their 90-day chip. Look at their brains. They still look markedly abnormal compared to the controls. This, by the way, if you were an addicted doctor, is right about when our physician monitoring program would let you go back to doing surgery. Is anybody here having surgery next week? Okay. This is what you're dealing with. Okay. So it's no surprise when the people that we turn loose from treatment go out and do incredibly stupid things because their brains are simply not woken up yet. So here's the controls, here's the 10 days clean, and here's the 100 days clean. All right. So let's say you go to an addiction specialist, I'm sitting there with our cigars and everything and our 3-piece suits, and you don't want to know if you're an addict. So there's a thing called the Diagnostic Service Manual, and there's a DSM-4 and there's a DSM-5, and I'm going to show you a little bit about how they're mixed together, and then I'm going to show you the real way you want to do it. So using the DSM-4, which is talking about addiction or dependence, you're supposed to have 3 out of these 7. Tolerance, withdrawal, you take more than you planned on, you can't cut down, you can't stop using, you spend all your time getting it, using it, and getting over it. you give up everything else in your life for it, and you use despite a physical or a psychiatric problem. Up until a year ago or a year or two ago, if you had 3 out of the 7, we would say, okay, you're addicted to cocaine or alcohol or whatever it is. Okay? Now the problem is that a lot of people who have medical problems will have tolerance and withdrawal. They spend all their time getting their medications. They give everything up to get their medications, and the lines are kind of blurry here. Okay? So another one that was added with the DSM-5 is you also have craving. So in the DSM-5 they said people who have addiction, one of the criteria is that you have to crave it. A better way to look at it is what we call the 4 C's. If I don't have it, I crave it. And that's why craving is probably the most important criteria. I have to use it just to feel normal. That's compulsive use. I can't control it. Whoever wrote that commercial about we bet you can't eat just one, they understood addiction. So I may plan on having 1 beer tonight, but I wind up having a case and I wake up in jail. I can't stop once I start. And I use despite consequences or use despite harm. And you can throw in a 5th one. You can talk about chronic use. We don't diagnose dependence or even abuse on one episode. We have to have repeated episodes in order to diagnose it. So if you see these 2 folks on the way home, you don't really have any problem saying that they have a problem with alcohol or drugs. Here's a heroin addict. Here's an alcoholic. I need cash for alcohol research. And these are folks who probably their lives have been taken over by their drug use. But if you smoke, you're an addict. You have all 7 of the DSM criteria. You have all 5 of the 5 C's, and the chance of your quitting successfully is very low. More people smoke coming out of drug treatment than going into drug treatment. That's how bad it is. Here's a picture. This was taken one night from Jim Ballmer's computer when he's sending out emails, and you can see the cigarettes and the vodka, and he's been staying up a little too late. Here's someone from the Greektown Casino, and I have never seen this gentleman on TV, but I was told he lost like 400 pounds and got married. So these are all behavioral addictions. They share the same brain scans and the same problem as drug and alcohol. Here is a normal person, and the black here is dopamine. Here is a methamphetamine addict, and you can see how badly they've lost their dopamine. And here's another addict down here, and look what their drug is: food. Obese patients have the same brain scans as methamphetamine addicts. It's the same pathway, and it can be just as difficult to treat. Now, the first time I heard this at a 12-step meeting, I thought they were talking about some kind of religious affliction or religious compulsion. Someone will get up and say, I'm cross-addicted, or I'm addicted to other things, or I have addiction transfer. And the people that go to these meetings know that it is very easy to slip from one addiction to another. They've learned it often the hard way. And we didn't catch up with this for years, but if you went to an AA or an NA meeting, they knew what they were talking about. So people, for example, who are alcoholics and go into treatment for alcoholism will often have extreme weight gains, like 100 pounds. They will either start or increase their tobacco use, they'll gamble, they'll become addicted to pornography, they'll develop a sexual addiction, internet addiction, and they can trash their lives almost as effectively as an alcoholic can. And this is something that's difficult. You tell somebody, you're got 3 months clean from alcohol and you're going to the casino every weekend. I don't think this is a good idea. And the answer you will get is, it's not my drug of choice, don't worry about it. And we'll talk about that in a little bit. People who have gastric bypass surgery, which is the only real surgical addiction treatment done in the U.S., frequently become alcoholics because when they drink alcohol, it hits them as fast as IV alcohol, and it's incredibly rewarding. They often become addicted to pain medications and to sedatives. And the hospital I work at downtown, aside from the pregnant patients that I see for consults, which is that's what I do for a living, this is the most common consult I get in the hospital. Patients have bypass surgery and become addicted. So this is a bunch of terminology we're going to talk about. There's abuse, dependence, and substance use disorder in the DSM-4 and the DSM-5, And if we actually had something to do for a living, we wouldn't confuse you with all this. But someone has decided to do this. So I'm going to give you a little scenario here. So you've got a best friend, you're worried about them because she has been drinking heavily for 20 years since high school, and they've just told her she has high blood pressure and high cholesterol, and they've told her it's because of drinking, and you tell her that, and her doctor tells her that you think she ought to quit. Now, you've been to this lecture and you know that addiction is a disease and you can't walk away from a disease. You know that she will not be able to stop. And to your surprise, she stops without any problem. Okay? And you vow never to waste your time going to another Don Farm lecture. So, how did she do it? How does someone drink too much and just stop and walk away from it? Okay? And this is where the concept of abuse and dependence come in, which has been really muddied in the past year or two. Abuse is considered being a screw-up, basically. So failure to fulfill your work, social, or school obligations, use in risky situations. The most common example is drunk driving or going to work drunk and risking getting arrested. Recurrent legal problems has been taken out, but it used to be if you had more than one DWI, that qualified as being evidence of abuse. And continued use despite social or interpersonal problems. MOR stands for Marriage on Rocks, if anyone has read the book. And you have never been diagnosed with full-blown addiction. If you had one or more of these, you had abuse. If you had the other criteria, you had addiction, and the two were considered different. So here's what's going to happen. The majority of people you see in your life who have problems with drugs and alcohol are not addicts. They are abusing it. They are going to stop. They are going to walk away from it. And this has been written about by a lot of people who criticize addiction treatment, a lot of people who champion it, like Dr. White. And the idea here is that the majority of patients have a low level of substance use disorder or abuse, and it is not addiction, and it is something that will stop when their life changes. And the way to tell is, does somebody have craving, compulsion, and use despite harm or use despite consequences? Those folks, if they cannot not drink when it is absolutely critical not to, they're the ones who have alcoholism. And I just put this in here. Abuse is considered now a mild SUD. It's not a car, it's a substance use disorder. And then dependence is either moderate or severe SUD. And all the criteria from abuse and dependence were jumbled into one, and this was felt to be a huge advance, and it's a terrible mistake because it ignores the fact that addicts and alcoholics are different than people who simply drink too much. Addicts and alcoholics cannot stop. They may stop for a while, but they will always restart, and it's a serious, serious disease. Mark Minestrino, who used to be the director of detox at Brighton Hospital, had a phrase that I really liked. Abuse is a behavior, you're being a screw-up. Addiction is a true disease and needs some type of treatment. So a lot of people attack addiction as being completely made up. They think it's a government conspiracy, literally. And if you want some amusement, or if you want to see if you agree with them, the person that I would go to read is Dr. Stanton Peele, PEELE.net, and he talks about how addiction being imaginary and how it is part of a passage through life. So read it and see what you think. But they say that there is no addiction because most people stop on their own, most people stop without treatment, and even heroin addicts will quit. People can quit using heroin. Most people who came back from Vietnam stopped using heroin on their own. So let me turn it around and give it from my perspective. I'm a former cancer surgeon, and I used to take care of patients that have ovarian cancer. And I want you to look at these slides. These are two women who are 45 years old, and they both have ovarian tumors, which means growths. And the pictures are almost exactly the same. And you got to figure out which one is cancer. This patient has no family history of cancer. This patient has a family history of breast cancer and maybe ovarian cancer. This patient has, if you do a DNA testing, has no genes that predispose her to cancer. This patient has the BRCA gene, BRCA. You may have heard about it. This is one of the genes that Angelina Jolie had, and she decided to have prophylactic surgery. It affects both your ovaries and your breasts. So this is a strong DNA risk for having cancer, for having a disease, okay? Now, I don't know either of these patients. This is just 2 slides taken off the internet, but I can tell you that this patient did not die from an ovarian tumor, and this patient is certainly, almost certainly, already dead from it. And this is a difference between simple abuse or risky drinking and addiction. So let me take it one step farther. If I was to stand up here and say, most ovarian tumors are benign, ovarian cancer is actually rare, and you don't need to treat most ovarian tumors, this is a government plot. You would, A, call me an idiot, which I hope you would start with, B, have my medical license suspended, or C, put me on the speaker circuit. Nowadays, if you come out and say nonsense like this, you get to go on the speaker circuit. And I'll show you an article, if you want to reference it later on, from the Atlantic, which was just complete and utter trash and was advertised as a scientific attack on AA. We'll come back to it. So, let's get back to the relapse. My old boss, Herm Malinoff, used to always say, anybody can quit drinking. All you have to do is walk up and hit a cop. And you will be invited to abstain from drinking for an extended period of time. You may be offered treatment during that time, but as long as you are on a city or county jail where they don't have as much commerce going through, you probably won't be partaking in any alcohol or drugs. But when you get out, you will probably start drinking again. And I used to volunteer at the Washtenaw County Jail, and I would see every 30 days the same poor sad sacks, and they would come in and would say, this time I'm going to stop smoking dope, but I'm not going to stop drinking. Or this time I'm going to stop drinking, but I'm not going to stop smoking dope. And I would say, well, let me know how it turns out, and I would have a chance to find out, because they would be back a month later. They just hadn't stopped. So we know now there's 3 main causes that you relapse. One is being exposed to the drug, and you'll hear all the time about somebody going and getting their 30-day chip at an AA meeting and stopping at the bar on the way home to have one drink and waking up in the county jail. Or stress will cause relapse, and you hear people say, I can't stop now, I'm just under too much stress. Or cues. You walk past the bar, you walk past the dope house, you see a picture or something on TV, and before you know it, you're using. We now know where that comes from in the brain. This is, again, a rat's brain, and now we turn the brain around, so that's the front and that's the back. And drug-triggered relapse happens when you tell the gas tank to pour gas on the pleasure center. So it's triggered from the VTA. It's a dopamine pulse. I have one drink tonight and I'm off, and you just can't stop me. If it's stress, it's corticotropin releasing factor, which comes from a higher part of the brain and affects the lower part of the brains, including your pleasure center. And you may have heard of cortisol and CRF on TV. They advertised it as a weight loss product. I wouldn't advise trying it. Or the cues, there's 2 parts of your brain called the hippocampus and the amygdala that are associated with emotional memory. So, I've quit drinking, but I walk past the bar and I hear the sounds of the TV set and the glass and all that stuff. And just that cue just draws me right in. And I just don't have any way of stopping it. Those are the 3 main ways that you relapse. So let me just show you some pictures of alcohol and drug cues and non-alcohol and drug cues. So this is Ray Milland from Lost Weekend. This is a fantastic movie up until the last 5 minutes when his girlfriend cures him. But if you want to see what alcoholics go through, you should watch it and then turn it off 5 minutes before it's over. This is cocaine, and they can actually show that if you show this picture to a cocaine addict, you will trigger a dopamine release, and then if you show him a picture of Bambi, there will be no dopamine release. This is something that often gets people going if they're trying to quit smoking. Here's somebody again hanging out at the Greektown Casino, and here's our friend here staying up too late on the computer. And here's food. We used to have a separate talk on food addiction, but basically it is the same as the others, and we'll talk a little bit about treatment. Now, as far as drug goes, there are a combination of drugs that are very popular, very potent, And if you have a friend who is taking these drugs, your friend has a problem. And the old one was the dynamic duo, which was Xanax and Vicodin, or now called Norco. And the newest combination is called the Holy Trinity, which is a combination of Norco, Xanax, and Soma. This is an incredibly rewarding combination. I know doctors in Detroit who in their entire medical practice is writing these prescriptions. They don't write for anything else until the DEA shows up and puts them in the back of the car. And this is, if you know anybody who's on this combination, this is not for pain, anxiety, or anything else. This is addiction. Okay, so let's talk a little bit about the side effects and the consequences of addiction. This gentleman is going to wake up with a very stiff neck, and it says in the bottom, rock bottom, you'll know it when you get there, okay? So first off, for alcohol. People who are alcoholic often have high blood pressure. And if you go to your doctor and they tell you, well, you got high blood pressure, and you say, why? And they say, well, it is essential hypertension. And what that means in English is, I don't have the faintest idea, okay? That's what essential means. A major cause of essential hypertension is a closet alcoholic who wakes up every morning in withdrawal with a high blood pressure. It damages your pancreas. You can have chronic pancreatitis, which can be fatal. It makes your cholesterol go up. It makes your good cholesterol go up some, but it makes your bad cholesterol go up more, and your triglycerides or your fats go way, way up. And it can be fatal again. Now, as far as damaging your liver, you start off by having a fatty liver because all your calories are being taken from alcohol and they get converted in fat in your liver. This is somebody who wakes up in the morning after a binge and says, wow, that hurts. So their right side will hurt. You can get alcoholic hepatitis, which is a whole different ball game. You get a fever, you turn yellow, and the chance of dying is 10 to 15%. You really have damaged your liver. Or you go on to get hepatitis. And you can also have viral hepatitis, which can occur mostly from hepatitis C. And then finally, cirrhosis is where the end stage is scarring of the liver, and a liver does not recover once it gets to that point. So let's go back to your friend here. We got a different friend now, I'm sorry. You got a friend who's an alcoholic. His family took off. When you see him today, he denies he has a problem, but says he's alone now because he needs to take a break. The reason his wife left was his mother-in-law. And you talk to him, and you're amazed because he rationalizes, defends, deflects, minimizes, and everything else you talk about when you take a psychology course. He's completely full of it. He has no insight and no judgment. And that is a feature of an alcoholic mind. For some reason, when people become alcoholic, they lose all their insight and they lose their judgment. We always talk about recovering addicts make bad decisions. I had a gentleman who I was actually sponsoring in AA. 3 weeks after he got clean, he decided he was taking a vacation. Now, most of us will take a vacation out to a campground or someplace. He went to Amsterdam. It didn't go well. When he came back, one side of his face was almost entirely rubbed off, and he couldn't tell us why. So he went back to Brighton Hospital. And there's a joke in AA talking about how people tend to rush into relationships when they're in early recovery. What's an alcoholic bring on a second date? And the answer is a U-Haul, because they're getting married and they're going off on their honeymoon. So here is a normal 40-year-old brain, and this is all white matter, and here is a shriveled up alcoholic brain. The brain is actually pulling away because it's shrinking and shriveling, and that's not reversible. This is a brain of a 70-year-old in a 40-year-old body. And we've talked about this already. Here is a normal series of people, and here, if you look at the amount of dopamine and compare it bottom and top, normal smoker, normal alcohol, normal food, normal cocaine. And that's not just a result of drug use. That's probably the reason they use drugs, is because they had less dopamine. So you see your friend a couple of years later. He says he knows you, but he can't remember your name. And that kind of makes you nervous because you've been friends for like 30 years. And he starts answering questions very strangely. He won't give you a direct answer. You ask him, how are things going? And he gives you some nonsense answer. And you ask him, how long you been here? And he'll say, it doesn't matter, I'm retired. And you start asking him questions like, who's the president? And he says, well, they're all crooks, doesn't matter. And you realize what he's doing is confabulating. He's making up answers so that you don't realize that he can't answer the questions. And he walks with kind of a gait like this, and when he walks around, he has to put his hand on the wall, and you realize that his balance is completely gone. The back of his brain, the cerebellum, is permanently damaged. So what happens first when you quit drinking is your brain can stop bleeding, and this is called Wernicke's encephalopathy. And it's a small part of your brain that actually starts hemorrhaging, and it can kill you. And people will wind up, their face is paralyzed, they can't move their eyes, they can't talk, they can't tell you where they are. And if you treat them immediately with vitamins, they'll recover, but then they go on to something called Wernicke's or Korsakoff's psychosis, which is much more serious. And what happens is, we just talked about this, you start making things up because you don't want people to know that you can't figure anything out. You have amnesia. There's retrograde amnesia and antegrade amnesia. In retrograde amnesia, which is behind you, I'll ask you, tell me 3 things that happened in the news for the past week. And you'll say, I don't watch TV. That'll be your answer. That's confabulation. And then I'll ask you to remember 3 objects, cat, pillow, and chair. And what I'm supposed to do is come back and ask you 5 minutes later to repeat those 3 objects. And if you can't do it, that's antegrade amnesia, forward amnesia. My problem the past few years is I can't remember to ask you the things after the 5 minutes are up. So I go back and look at my notes and say, oh shit, I didn't ask, what am I going to do now? And you can have peripheral nerve damage, so you have neuropathy. So you have numbness in your hands and feet, and you can't walk, and you can't really do things anymore. So things go on, and you see this gentleman one more time. He's been brought back in the hospital, and he's throwing up blood. He has jaundice, and he has encephalopathy, which means his brain is not working. He has what's called esophageal varices, which are dilated veins. I'm going to show you a picture of it in a couple minutes. And he's turned yellow because the bile is backing up into his blood because the liver can't detoxify it anymore. And he starts talking about his sister paying for a liver transplant, and his sister died 5 years ago. And he also, when he walks around, he goes like this. He jerks. And the reason he's doing it, it's called asteriscus, and it means that your blood is full of ammonia because your liver cannot detoxify the ammonia anymore. So it's like people are going to fly right out the window. And it's very, very difficult to treat. So we're talking here about someone who has cirrhosis, and that means scarring of the liver. The blood backs up because it can't get through it, and I'm going to show you a picture of what varices look like. I'm not going to show you hemorrhoids. We'll pass on that one. But you can't metabolize the toxins in your blood, so you become confused, and you can't make the proteins you need, so your blood clots, so your blood will not clot, and you can bleed to death just by nicking yourself. You don't have any protein left in your body, so your body just bloats up. And here's a healthy liver, and here's a cirrhotic liver. And I've seen these, and you can go like this, and if they feel like wood. I mean, they're completely scarred. Here's somebody who looks like they belong in my OB clinic, right? They look like they're about 8 or 9 months pregnant. The problem is that my patient here has a beard, okay? And if you look over here some way, you see the telltale sign, Veterans Administration. This is a gentleman who has cirrhosis and ascites, which is fluid buildup from some cause of cirrhosis, either alcohol or hepatitis C, and they can't keep the fluid from building up in his stomach. There's a spot over here where they try draining it off, but you have to come back every day and drain the fluid off. And eventually, they can't breathe anymore. This is something called caput medusa, and it's hard to see, but the veins are dilating because they're trying to get around your liver. It's a detour around your liver. This blood is supposed to be going through your liver and being detoxified. Instead, it's going from your rectum to your throat directly. And obviously, if you nick one of those veins, you can bleed to death. And you can see a bunch of iodine down here where they just tried to drain off a bunch of fluid. This is the inside of your esophagus, which normally is about thumb dilated, okay? And look down here. Those are supposed to be about 1/10 the size they are. Those are hugely dilated veins trying to get around your liver. Again, hooked up from your rectum to your throat. And if you nick one of those by throwing up or drinking or having too much acid in your stomach, you can die in a matter of a few minutes. I've seen patients lose about 20 units of blood in a matter of 5 to 10 minutes when one of these pops. And this gentleman's history is that he's going to die from liver failure. And Narcotics Anonymous has a perfect phrase. It said, folks who have addiction, if they don't get into recovery, what they face is jails, institutions, or death. Here's somebody who enjoys cocaine a little bit too much. And what you're doing is you're looking up into their sinuses, okay? Because the cocaine has eaten through, and this can really never be fixed. So when they talk, you're going to hear the air go right through their nose and come out their mouth. It's not pleasant. Here's somebody who died from infection of the heart. This is called endocarditis. And these are bacteria growing inside their heart because they injected the bacteria when they shot up heroin. This is anthrax, which you used to hear about like from the Middle Ages. It's back. You get it from injecting. And here's somebody injected in their arm, and they are probably going to wind up losing their arm from that. And this is called shooting the pocket. What you do is you want to get to these big veins here in your neck, so you hold your breath and you push down. That's called Valsalva, and those veins stand out, and someone injects you in there. Unfortunately, right about there is the top of your lung, and it's very common for someone to hit the pocket and then hit their lung and drop a lung. This person over here has MRSA. You've heard of flesh-eating bacteria. That's it right there. Food is a drug. And this is a gentleman who I think it was 3 weeks, he just lived at McDonald's, and he blew his cholesterol, his triglycerides, everything. His blood pressure shot up. He became pre-diabetic in a matter of a couple weeks. And if you don't think food is an issue, look at the big book, quote unquote, from Overeaters Anonymous, which is the 12-step program that compares to AA. And here's what they say. We've driven miles in the dead of night to satisfy a craving for food. We've eaten food that was frozen, burnt, stale, or spoiled. We've eaten food off of other people's plates, off the floor, off the ground. We have dug food out of the garbage and eaten it. That's addiction. That's not having a healthy appetite. Okay, so enough bad stuff. We'll talk about the treatment for addiction. Now, I started doing this, I think, about 8 years ago, and I gave what I thought was a really optimistic talk about how you can treat addiction. And, you're going to be asked to give comments at the end of tonight's talk, and here was one of the comments, okay? He's very depressing, okay? So I rewrote everything a couple of years later, and I redid it, and I thought, now I'm going to make everybody happy and buoyant and everything. And here's what they wrote. I left tonight without any hope. All right? So I started getting these emails from Jim Ballmer saying, what are you doing here? Okay, what's going on? So I redid it again, and I talked about, how great the 12-step programs are and how people can recover, and the comment was, a dark journey through the 12 steps. So I give up. I'm just going to tell you what goes on, and you can write what you want, okay? But before we talk about the solution, I want to talk about the problem, okay? And the problem is that if you're talking about opioids, the biggest problem nowadays is prescription drugs, and those drugs came sooner or later from a doctor's office, a doctor's prescription pad. This is the latest arrest made in Michigan and raiding a doctor's office. This was up in Glagwin, up north of here, and this is a doctor who's being accused of running a pill mill. And we want to know or want to talk about, why do doctors overprescribe? Why do they do this? Why would you risk your career just to write for some Norco? And we talk about the 4 Ds as the reason that doctors overprescribe: dishonest, dated, disabled, and duped. So for dishonest doctors, there are doctors who are just crooks, okay? And every field, every walk of life has crooks in them, and they generate an entire business just writing prescriptions, and they don't really care what happens. This is Dr. Oscar Linares, who was arrested down in Monroe, and when you went to see him, you would go into a room and there would be a TV screen like this, and he would show up on the screen and he would say, "What do you want?" And you would give him the menu, A, B, and C, and there would be a prescription waiting you on the way out, okay? And he wrote that he was too big to fail, and they finally took him down. And the reason I chose him, I always love it because there's that little U of M sticker there, okay? And because most of the doctors that get arrested worked at the Detroit Medical Center where I work, so I'm glad they got one of the U of M guys. Dated can be doctors don't keep up with continuing medical education. We're supposed to do 50 hours a year. Some of us do 50 hours a decade. And, it's possible that a lot of doctors don't know that these medications are dangerous. This is probably the smallest of the bunch. Or the doctors themselves are addicted. And this is a blurb from MLive talking about a doctor who overdosed at U of M in Christmas of 2013. He was found dead in the bathroom but was revived a few hours before another nurse had died and they didn't get to her in time. And doctors and nurses become addicts just like everybody else, and probably even more so. I showed you all those pictures of a damaged brains. If you're a doctor or a nurse or a pharmacist, what kind of decisions are you making when you're walking around with one of those brains? And then you can have duped doctors. And I think there's probably two groups of these. This is, I can't remember his name. This is the guy that was Michael Jackson's doctor. And he's a narcissist. And the common term for that is an asshole. He was giving Michael Jackson whatever he wanted because he wanted to be Michael Jackson's doctor. The other group of doctors, which is really the big one, are doctors who believe they're helping their patients when they give them whatever they ask for. And I have gone to talk to doctors saying, listen, you're on the radar. You need to stop writing for all this stuff. And they say, I must, because if the patient says they have pain, I must write medications for them. And they really believed it. We call that being enablers or duped, and they have what we call Al-Anon insufficiency. Now, these are the ones you're going to see written up in the literature. I actually created a fifth category. I should write about it. Let me skip here. Defamation. With the social media now and the internet, if someone doesn't like you, they will immediately go home and write something bad about you. And I just surfed the internet and I found this stuff written about doctors. He was rude and wanted me to jump through hoops. He walked out in the middle of the interview even though I didn't even ask for pain medications. The worst doctor I've ever seen. I'll never go back to him, okay? Now, actually, it turns out that doctor is me. That's me without a beard. And that's my wife. She's sitting right down in the front, and we have a private practice. And you can actually tell who does it because a patient will show up and they'll demand Norco and Xanax, and I'll say no. They'll storm out, and 3 hours later, I'll do a search, and there I am on, shittydoctors.com. So this is something that a lot of doctors, if you're not in private practice, and you're working for a hospital, you really need to worry about the kind of reviews you get, and this is the kind of thing you have to be concerned about. So, how do we treat addiction? There's medical treatments, behavioral, spiritual, and surgical. Now, briefly, surgical treatment is gastric bypass for treating of eating, compulsive eating disorder. And the other one is China. If you're in China and you're a heroin addict, you will be offered to have a probe stuck in, and they will ablate your nucleus accumbens. I wouldn't recommend trying it, but they say it goes very well. So, talking about medications, we're going to focus on two groups, agonists and antagonists. Agonists are similar to the drug you're trying to get off of. So for heroin or opiates, we're talking about Suboxone, which is buprenorphine, methadone, which is the old classic drug for opiate addiction, and if you're in Canada, you can go to a pharmacy, get a handful of dilaudid syringes, and just go out and sit in the park all day. But you can't do that here in the U.S. Antagonists, there's only one we're going to talk about, and that's Vivitrol. It's an injection of naltrexone, which is an opiate blocker, and I'm going to show you a study about it at the very end of this. There was a drug that was a blocker for your munchies brain site. The place where marijuana goes, it gives you that little craving for McDonald's in the middle of the night. They found a blocker for that. The problem was that even though patients lost a lot of weight, they became very depressed, so it was taken off the market. So just to jump ahead, these studies all have about the same results. They're about 40 to 60% effective. And a lot of these studies go out for years. So these medications work. However, and this is something you may never have thought of, if you stop taking a medication, the medication stops working. Okay? Now that sounds kind of obvious, right? But people who don't want you to take medications will say, well, it's just a temporary fix, or a judge will say it's just another drug doing the same thing. We'll talk about that. The other thing is that when you stop taking these drugs, your body is now very sensitive to the opioid or whatever it is, and you are more likely to die from an overdose. The time when you die from an overdose is when you stop taking medication or when you get out of jail, because your body is not used to that drug anymore and you don't know it. Why would you expect anything else to happen? Okay, the other thing is people don't want to keep taking a medication. And I have never started somebody on a medication, Suboxone, methadone, Vivitrol, and not had them ask, when can I get off this stuff? Okay? And the answer is when you want it to stop working. Okay? So I'm an OB, so I'm going to show you one study about pregnant addicts. They took 101 pregnant addicts, and they got about 40 or 50 of them to detox. And they thought this was very, very successful. Nobody had a miscarriage, no one died, and everything's going to be great. And this study is advertised as proof that you can detox during pregnancy. But if you read the fine print, at the end of the study, when the patients delivered, they found one patient who had a negative drug screen out of 101. Everybody else had relapsed. The natural history of untreated addiction is relapse. And they said, didn't work. No shit. All right. Here's another study from Europe. They took 40 addicts and they put everybody on Suboxone, heroin addicts. 20 of them got to detox, which is what everybody wants to do. And by the way, if you wanted counseling, you could do it. 20 of them were kept on Suboxone and offered counseling, and they were monitored for a year. A year later, the patients who had stayed on Suboxone, 75% were still clean, and nobody had died. Of the patients who detoxed, nobody was clean, and 20% were dead. Detox without follow-up does simply not work. Okay, this study is complicated, but it's the biggest study ever done on Suboxone and prescription pain pills. They took 650 patients and put them on Suboxone for 2 weeks and then tapered them. Why? Because that's what all the patients always want to do. So they gave it a try. Everybody relapsed. 94% relapsed immediately. Didn't work. So they said, okay, let's go on to phase 2. The patients who were still left, about 360, were put back on Suboxone, this time for 3 months, and then tapered off again. Why? Because that's what folks do when they relapse the first time. They say, okay, I'll give it a couple months, and then I'm going to come off it because I don't need it. I'm okay. 92% relapsed. Okay? The relapse rates are horrible coming off this medication, but while you stay on the medication, about 60% will stay clean. And the other bad news was that they found that it didn't matter whether or not you had counseling. The only thing that counted was whether or not you were on medication. All right, this is a huge study from New York City back in the 80s. And what they did was they looked at IV drug use in people who enrolled in a methadone clinic. 5 years of study. That's a huge study. 80% reduction, or 70-some% reduction in IV drug use in a methadone clinic. That is just astounding. That means that AIDS went down, hepatitis C, mortality, incarceration, everything. And that's an amazing amount of response. However, remember those brains, those addict brains, once you get to be hanging around for a few years, you say, well, it's time for me to move on. I don't need this anymore. I'm cured. 80% relapsed within a year, back on IV drugs. So this sounds depressing, but keep in mind that these drugs worked as long as you took them, okay? Another thing is ultra-rapid detox. I have one friend who did this. He's a veterinarian. He decided the authorities were after him because he was taking more drugs than the entire animal hospital he worked in. And he went to one of these ultra-rapid detox units, and he woke up with some guy carrying him across a lobby into a motel room, dropping him on the bed and just leaving. He had to wear a diaper for a week, and he's 40 years old. And the first thing he did when he got out of the motel was went and used. He said, I've had enough of this nonsense. I'm going to back with what feels good. So this is not considered to be successful. The next one is Vivitrol, which is an injection of something like Narcan. You've heard of Narcan being the rescue drug. This is a version of Narcan injected once a month. And this shows, this is always difficult to see, but this shows that the patients who didn't get the Narcan, or sorry, the Vivitrol, here's how long they stay clean. And the patients who got the Vivitrol, here's how long they stay clean. Now you can look at that and say that doesn't look like much of a difference, but in addiction research and psychiatry research, this much difference is a lot. And these were Russian heroin addicts. If you are a Russian heroin addict, you do not have a long life expectancy, and none of these folks died if they stayed on the Vivitrol. Here's something nobody expected. Remember I said craving is the worst part of addiction? And if you talk to somebody who just has gotten a year clean, and you'll say, so you've got a year clean from alcohol and drugs, what'd you think about for the last year? And they'll say, alcohol and drugs. And that's all I thought about, okay? The craving dropped 50% in the patients on the Vivitrol. And that probably explains the decreased relapse rate, because if you don't crave it enough, you're not as likely to use it. The problem is that if you stop using this and you go back out, you are even more likely to die from an overdose. And if you've gotten a shot of this medication, if you break a finger, you got to be admitted to the hospital to get IV pain meds. You can't just take pain pills. This blocks all your pain receptors. So, do you have to use medications? And the answer is no. The most successful programs in the country are three groups: doctors, nurses, and pharmacists, pilots, and lawyers. I hate to mix number 1 and 3, but they are. So these three groups have professional monitoring programs, and I'm the medical director of the Michigan program for doctors and nurses, that monitor you when you get in trouble, and the success rate is 85 to 95%. And these are all different programs. It's called HPRP, LJAP, and HIMSS, all different names, but they all do the same thing. They monitor you, they make you go to meetings, they make you get a therapist, and you do drug screens over and over and over. And this is the one for the Michigan program. So if you call them tonight and you say, I was at a hospital meeting and I saw Dr. Christensen drunk, they'll go, oh no, not again. But they will investigate and they'll see whether or not it's really true. And they offer all these things. And this one, especially, graded response. So if you have a little slip, you just get extra time and they intensify the treatment. If you have a full-blown relapse, we're going to pack your bags, put you on a train, and we're going to send you down to a program in Georgia for 3 to 6 months. And it probably will work. Now, what everybody says is, yeah, but doctors are smarter, and my response to that is I'm an OB-GYN, and that does not count. That's not valid. And they always say, well, doctors have more to lose. Who has more to lose than a mom that might lose custody of her baby? I mean, come on. That's not, how do you compare anything to that? But still that happens. The reason these programs work is because of the intense monitoring. There is a program in Hawaii called HOPE where they do the same thing to convicted drug felons that we do to doctors, and their success rate is the same. The program's the same, the success rate is the same. It's not because you're a doctor or a lawyer. It's because you have intense monitoring. The problem is you can't do any of this unless you have a gun to someone's head. Like, we're going to take away your license or we're going to put you back in prison. So if someone comes to see you and they say, I'm going to put you in our intensive monitoring program, and there's nothing to keep them in it, the first time things go wrong, they're just going to wave bye-bye, and you're just not going to see them again. And we just talked about this. It shows up again. Okay, I'm going to skip through this because I'm not qualified anyway. So we're going to talk about a spiritual solution for treatment. And this is where the 12-step programs come in. And this is, if anybody's interested, this is the hotline for AA in the Huron Valley area. And that is the website for AA in southeastern Michigan.org. And you can go on there and you can find contacts, you can volunteer, you can find meetings and everything else. However, there's a lot of resistance to this, okay? And we talked about this before. You can go on peel.net and you'll see stuff like this. God is not great. God is actually the cause of evil. Or you'll see this program called Rational Recovery, which claims that they can teach you to recognize your lizard brain in one session and cure you for life. but that you don't need to go to any 12-step meetings. And this kind of stuff goes on and on and on. And this is the latest article that came out. It's called The Irrationality of Alcoholics Anonymous. It's gotten a lot of press because it was in the Atlantic, and it's the best description, to say it politely, is just tripe. And if you want to read it and, assess it for yourself, but it's simply talking to people in Europe and the U.S. who don't like AA, so that's the reason why AA doesn't work. But what they do is they ignore every study that shows that AA works. And when I talk to someone about going to 12-step meetings, immediately they throw up religion. They'll say, well, I'm a recovering Catholic or whatever, and I don't believe in religion, and this is not for me, and anybody who does believe in this is an idiot. So I was always trying to think of something that I could rebut them with and, show that, there are other organizations who have spirituality. And I would ask people, I say, can you name an organization that believes in God, in turning yourself over, taking direction, and living for a higher purpose? And they'll start muttering, and I'll say, well, how about this? Okay? And this is, the motto is God, country, and core. And if you drive around, you see these, these signs that say a commitment to something greater than yourself. And what I tell them to do is, if you think this is really stupid, why don't you walk up to one of these guys sometime and tell them, how stupid their program is, and please let me know how it turns out. So here's where the 12-step programs come in, and I think there's something like 200 of them, and they are designed to be tailored towards your specific addiction. AA is a grandfather, followed by NA, and then all the other ones followed, OA and gamblers and sex and cocaine. And these are the big ones here in the area. And the first thing is, does it really work? And I want to refer you back to a huge study done back in, I think, the 90s or 80s called Project Match, where they compared AA to cognitive behavioral therapy to motivational enhancement, which are two different other therapies, and they looked to see who did better. And this is, on the left is 1 year AA. I think this was, this is motivational enhancement therapy, and this is cognitive behavioral therapy. And the bottom line is they all did equally the same, and AA did a little bit better. 3 years later, it was even more remarkable. That's AA, that's motivational enhancement, and that's cognitive behavioral therapy. AA does work. These folks were randomized. How about the most difficult group, which is veterans? They have a lot of co-occurring trauma. They have a lot of psychological disorders after they come back to the States. And these are people who went to 12-step at 1 year, went to 12-step at a year and a half later, didn't go to 12-step at 1 year, and didn't go to 12-step at a year and a half. There's obviously a dramatic difference between those who went and those who didn't go, and this went out to a year and a half. How much does it take? More is better. This is looking at a 3-month period, how many AA meetings the veterans went to. So here's 0, here's less than 20, here's less than 50, and here's more than 50. It's a straight line. The more meetings you go to, the better your recovery is. Now you can argue, well, these are people who are going to do better anyway, so they just went to AA, so AA doesn't matter. I don't know. But I can tell you that someone who goes to meetings regularly, who is an alcoholic, has a better chance of recovering than someone who doesn't. Surgical we talked about. Also, I forgot to mention that liver transplant, the most common indications are Tylenol, which is Norco, hepatitis C, and alcohol are reasons for liver transplant in the U.S. So why bother to do all this stuff? Okay, usually by this part of the talk, everyone's going, Jesus, I just want to get out of here. And this is a picture that demonstrates what happened to 33% of our counselors down at the old Jefferson Clinic on Jefferson. And this is an occupational hazard, and it's the kind of thing that kind of sours you towards people with addiction. So this was a paper written by Tom McClellan in 2000. For a short period of time, he was the drug czar of the United States, and he compared addiction to other chronic illnesses. And he found that addiction doesn't have a great prognosis. He said 40%. Remember I told you 40 to 60% success. He said, well, most addicts are, if they really try, have a 40% success chance. And there's a lot of reasons, and you can make up a lot of reasons, and there's a lot of valid reasons. But a lot of people say, well, if it's only 40%, why should we bother? Well, your diabetics have a 60% success. Your asthmatics are 40, hypertensives are 40, and drug dependence is 40 to 60. Guess what? Chronic diseases all have about the same success rate. They are incurable, but treatable. And keep in mind, I'm not talking about abuse. I'm not talking about the college kid who hangs out too much in the dorm and drinks. When you take him out of the dorm, he stops drinking. That's abuse. That's not addiction. I'm talking about real addiction. So if you were an insulin-dependent diabetic and you got fed up with watching your sugar and just stopped taking your insulin, went into a coma and wound up in the hospital, your doctor would come around and say, listen, you idiot, go back on your insulin. You almost died. Here's a script. I'll see you next week in the office. But if you're an addict and you stop your 12-step meetings, your Suboxone, your methadone, and you relapse and you wind up in the ICU, I'm going to come around and say, I've had it, you're hopeless, you're an addict, you're discharged. All of us have done it. I've done it. It's a natural human response because addicts who are not in recovery can be really, really unpleasant people, and they tend not to tell the truth, and it gets really, really frustrating. But it's been shown that methadone maintenance and followed by Suboxone maintenance treats all these things: HIV, hepatitis C, incarceration, and death. And the other thing Dr. McClellan said was, what we showed you before, is detoxing somebody and then turning them loose simply doesn't work. It has to be a detox followed by treatment. And addiction should join this list of chronic, incurable, but treatable diseases. Okay, so I'd like to wind up with looking at different characters. This is two of our dogs, and this is a Bouvier here in the back, and this is a lab. Which one of these is an addict? The answer is this one in the front, okay? This dog was such a food addict that we used to chain the refrigerator shut, and as soon as I left, he would come out and break into the refrigerator. He would routinely eat a loaf of bread and a head of celery just for breakfast, and it got to be impossible. And what we did was, when he finally passed away from arthritis, we knew how much he loved food, so we put him up on top of the fridge, and he's waiting for everybody at the Rainbow Bridge. So I just want to acknowledge the people I work with. This is the old Jefferson Clinic, now called the Tolan Research Clinic, and we got one member here tonight. And these folks take addicts who really don't want to stop using. They just want to stop being sick, and we have about a 25% success rate in getting them abstinent. And these are folks who have been bounced around from treatment center to treatment center, and they have really, really been down the road, and I think we have an amazing rate of success. This is our private office, and there's obviously an order of importance here. I'm at the bottom right. This is my wife, Kathy. She's down in the audience. Wave, Kathy. This is Sherry, the boss, and this is our pet therapy dog. This is Olive. So we're over off Washtenaw. And this is contact information for me, and I am done. So thank you.